Hello, everybody. All right, I think we'll just wait like one more minute and then we'll go ahead and get started. Can let people in after the fact as well. Okay, I think we'll go ahead and get started. Thank you, those of you who have joined us. We are excited to do this. This is our third monthly IVF 101 webinar, and this month is hosted by Dr. Grindler. So we're going to go through some slides. She's going to kind of do this presentation, but keep it kind of brief so that we allow plenty of time to get to your questions. Again, this is kind of a general overview. We don't want to give any, really get into any like real specifics as far as medical advice goes. So, but feel free to answer or ask questions. And if we kind of need to generalize it a little bit, we can. I'm Bridget. I'm one of the physician liaisons. So I work with all of our providers, and I was a former IVF nurse. So I have a really good kind of understanding of the entire process as well. But we just think this is a really good way to kind of do an introduction and, just kind of, there's a lot of information around IVF. And so this is just a good way to kind of get your feet wet and, again, have an opportunity to really ask questions. Okay, so I'm going to hand it over to Dr. Grindler and let her get started.
Thank you. Well, hi guys, I'm Dr. Grindler. It's so nice to meet some of you this way virtually and connect this way. So my goal for today is not for you to leave here as an expert in IVF. You will not become a board certified REI after this presentation. My goal is really just to start introducing you to so many of the terms and abbreviations we use commonly when we're talking about an IVF cycle, so that you're more comfortable with the language moving forward. So that's me. And in general, infertility really is defined based on your age. So if you've been trying to get pregnant for a year and are under the age of 25, then you have the diagnosis of infertility. Whereas women who are older than the age of 35, it's really, the definition changes based on their age. And so it's only 6 months if you're over the age of 35. In general, it's important to recognize that what the menstrual cycle is, so that you understand some of the terms we use in IVF to describe how we'll be treating you. So in general, in the menstrual cycle, the follicular phase, or the first part of the menstrual cycle, is where your brain is producing hormones that your ovary sees so that a follicle grows. So that's the follicular phase. As that follicle grows, it secretes estrogen or estradiol. And once the estradiol level gets high enough, that's when your body gets a signal to ovulate. So ovulation happens with the LH surge. So many people are aware of the LH surge because of ovulation predictor kits. And so ovulation predictor kits are actually measuring the LH surge that happens because it's received the message from your ovary that the estrogen level is high enough and that there's a follicle ready. After ovulation, the luteal phase starts, and that's the phase that's really preparing for implantation and pregnancy. And if you don't get pregnant, you get a period and the cycle starts over again. In general, in order to get pregnant, we need 4 things. We need a healthy mom to carry a pregnancy. We need sperm, egg, and then normal anatomy. And so I think it's always helpful to just break it down into those 4 things, because the evaluation really just helps walk us through each of those 4 things. So in general, when we're thinking of causes of infertility, it can be a problem with any of the 4 things we talked about. So for example, if you have too many eggs and you're not ovulating, then that can be a cause of infertility related to polycystic ovarian syndrome, or PCOS. Or you could have too few eggs and have diminished ovarian reserve, or primary ovarian insufficiency. There are couples who have physical blockages preventing the sperm and egg from meeting up. So if a woman has blocked fallopian tubes, that's tubal factor infertility. And then there are sometimes male factors that contribute to this as well. So if a man has an abnormal semen analysis, then that could be a cause of infertility as well. And then just a quick shout out for our LGBTQ population. The way that I practice, I don't assume that you have infertility, right? That a lot of times you just need to be exposed to sperm at the right time of the month. And so I really personalize your care because I understand it's not necessarily infertility, but rather a lack of sperm exposure. So in general, the testing focuses on looking at 4 of the things. So first, we'll do testing to prepare you for a healthy pregnancy. So most often that involves blood tests to make sure you're immune to all the diseases you need to be and that your hormones are optimized prior to getting pregnant. It's also at that stage that we're making sure that all your healthcare maintenance is up to date, like your pap smear, if you need a mammogram, because at the end of the day, we have the same goal. I'm not here just to get you an embryo. I'm here so that you have a happy, healthy family after a healthy, happy, uncomplicated pregnancy. And so that's why it's worth taking the time to make sure your healthcare maintenance is up to date. The next thing we need in order to get pregnant is we need eggs. And so we test ovarian reserve several ways. Ovarian reserve is a fancy way of saying how many eggs you have compared to someone else your age. And the reason it's important is because it helps you understand if you do IVF, how likely you'll respond to the medications and helps me plan for the medication dosing. But it also helps me plan for the fact that you may want to have more than one child, and that everyone's family size goals are different. So how are we going to plan for your pregnancies to make sure your family size goals are met? The way that we test ovarian reserve is with blood tests like AMH blood test, FSH blood test, as well as ultrasound. The other thing that is needed for the sperm and egg to meet up is normal anatomy. And so most patients with infertility will undergo testing called an HSG or hysterosalpingogram, which is an X-ray test, making sure there's no physical blockages preventing the sperm and egg from meeting up. And then guys, we also need a semen analysis to make sure you've got sperm. And so in general, we review this at the consultation, but the things that are at the regroup consultation prior to IVF, but in general, the things I'm looking at is making sure that there is sperm and that the swimmers are swimming and that the swimmers have a normal shaped head and tail under the microscope when you look at it. So those are the 3 most important parameters I look at when I'm considering IVF for a couple and their likelihood of being successful if they have male factor. So in terms of the phases of IVF, the first part is really, it's not on here, but it's called, you'll also often hear your IVF nurse talk about it. It's called luteal priming, or what you're doing in the cycle before you start IVF. So if you remember, ovulation happens and then you have a luteal phase before you start your period. And so it's often during that time that we'll put patients on things like birth control pills, estrogen pills, testosterone gel, to really synchronize their ovarian cohort to make sure they're prepared for IVF. So once we do that luteal priming, we then start the medications for IVF. So remember, naturally what's happening is your brain produces hormones, specifically FSH and LH, to get your ovaries to grow one egg. So the medications in IVF are actually the same hormones that your brain's producing, FSH and LH, but we're giving it to you at a higher dose because we don't want to just grow one egg, we're trying to grow multiple eggs. And so the medications are available exclusively as subcutaneous injections. And so you would give yourself daily shots in your belly every day for about 10 days. Once you have responded, then we would trigger you for something called an egg retrieval. The egg retrieval is done in our Littleton office. All the other ultrasounds and blood tests can be done at whichever office location is most convenient for you. And on the day of egg retrieval, that's when you would have IV sedation. So you'd be asleep and pain-free, but breathing on your own. And on that day, I would use a vaginal ultrasound to safely place a needle into each ovary to get eggs. On that day, the eggs and sperm are combined to create embryos. And when the embryos grow in the lab for about a week until they're hundreds of cells big, or what's known as a blastocyst, or a blast. And at that point, we can safely remove some of the cells from the outside of the embryo without damaging the embryo to make sure that it's healthy. As we're waiting for those genetic test results to come back, the embryos are frozen. And the best part of that is that they are as healthy on the day we freeze them as they're going to be 15 to 20 years from now. And so most of our patients are not waiting 15 to 20 years before embryo transfer, but you've got that option in case you want to. And so ultimately, after step 4, there is a phase that we pause before embryo transfer, and that can really vary depending on individual circumstances. So this is a sample timeline. That's what everyone wants to know at the first visit is, when am I going to be pregnant? I usually like to say, it's so nice to meet you. Can we talk first before I give you a timeline? But I get it. Like, you guys, by the time patients come to meet with me, they're already, ready to go, and so am I. So in general, at the first visit, my plan is to really understand your family size goals, understand your history, and complete any diagnostic testing that hasn't already been done. I always tell patients that expect that process to last a month. And the reason the testing takes a month is because some of the tests are menstrual cycle specific. So that means it could take less than a month, but it depends on where you're at your cycle at that initial consultation, whether you'll need to wait a full month or not. I am super efficient. I think all my nurses will tell you that I'm super efficient, and I will put in your orders that same day. So once my nurses tell me that IVF orders are ready, or a patient's ready for IVF, you don't have to bug me. I will put in the orders that day. And then it's really up to you to coordinate your schedule with the business office who handles the financing, as well as your IVF team, your IVF nurse, who's going to help coordinate the details. So the details of the calendar are really just so that you can plan your life accordingly. IVF in general, the process of growing multiple eggs and then creating embryos, that process takes 6 weeks to lead to egg retrieval. And then typically you'll meet with me again after egg retrieval before embryo transfer. And it's really at this phase here between egg retrieval and embryo transfer. At that visit, I talk about what we learned in IVF. So, if your diagnosis was unexplained infertility, what did we find? What did we learn? How did you do in IVF? And then ultimately, it's at that visit that we talk about the plan for pregnancy or embryo transfer. You would then, your nurse would change from an IVF nurse to an FET nurse, or frozen embryo transfer nurse, who will do all the timeline discussions for you regarding embryo transfer. And then, far in advance, you will know when to test for pregnancy. And in general, I love taking care of patients. I love seeing patients get pregnant, but I haven't delivered a baby in 8 or 9 years at this point. I am also not very friendly at 2 a.m. So you don't want me there in your delivery room. I love a lot of my patients, but you still are better served going back to your OBGYN. So all of our patients go back to OB, to their referring provider, usually around 7 to 8 weeks of pregnancy, depending on your insurance. All right. And so this is kind of just what I already kind of went over, but basically at the initial consultation, I'm here to learn all about you, your family size goals, and identify any tests that are outstanding. It's also at that visit that you can meet with the business office to understand what, if any, insurance benefits you have and what hoops your insurance company may make you jump through. Then you'll meet with an IVF nurse when you're ready for IVF, who goes over your calendar. And so it's really at this phase that all the patients want the details, right? You want to be able to plan your life accordingly so you can plan your work or personal life as to when the busy part will be with the frequent injections and monitoring. So in general, the protocol involves 2 to 4 weeks of preparation for the ovarian stimulation, where you're giving yourself shots. And then the injection medications vary, but in general, we tell patients it's an average of about 10 days. We are monitoring lots of different things during an IVF cycle. We're monitoring your follicles and how big they are on ultrasound. We're also measuring your hormone levels, like your estradiol levels, to see if your estrogen is rising at a rate that we would expect, that we see it is associated with good outcomes. And so what's important to know is that we're using lots of words interchangeably. And when you're seeing something on ultrasound, or what's called a follicle or a simple cyst, those are the same thing. We don't necessarily know if there's an egg in each follicle until we get to egg retrieval. And I think that's important to know, because Sometimes patients come into egg retrieval expecting just an unrealistic number of eggs because not every follicle is going to have a healthy egg in it. And then after egg retrieval, most patients will take some time off. So in general, I tell patients it's going to be at least 2 months after egg retrieval before embryo transfer. It's during that time we'll do a closer look of your uterus. So specifically hysteroscopy, where we place a camera into the cervix to look inside the uterus, trial embryo transfer, and uterine artery blood flow measurement. Transfer protocol really has varied. Typically, we used to manage everything or do what's called a standard medicated cycle, where I control everything, your estrogen, your progesterone, I micromanage everything, and we know it months in advance. There are some patients that also consider doing something called a natural cycle, where we're letting your body do its thing and you're ovulating on your own, and we're planning your transfer based on when you ovulate. And so the decision between medicated cycles and natural cycles really is up to your primary physician, and worth reviewing with them to see which one you're a better candidate for. Something that is important and often confused is that we use a lot of different abbreviations. So we're all talking about the same thing: PGTA, CCS, PGT. That's all the same thing. It is basically just where we remove some of the cells of the blastocyst, or your embryo, and we send those cells for testing. And what we're looking at is we're making sure that your embryo has 46 chromosomes, meaning we are not testing these embryos for every genetic condition under the sun. We are instead making sure that it's got the most important pieces of DNA that are needed for the pregnancy to implant and reduce your risk of miscarriage and reduce your risk of having complications like genetic conditions like Down syndrome. And so ultimately, we tell patients, most of our patients are choosing to do PGT testing, or also known as CCS testing or PGTA. So I know that was a ton of information. I'm here to answer questions. But first I was going to, while you guys are thinking of questions, I have some questions from my Instagram I was going to answer first. Does that sound okay?
Yeah, go for it.
Okay. So, and thank you guys for all the people that follow me on Instagram. I really appreciate being able to connect with you outside of the office. So, how much do you specialize treatment by person versus using standardized treatment? I think that really depends on the individual provider as well as the fertility clinic that you work at. And so, I'm unique. Our clinic is unique in that we are an independently owned private practice, which means that I don't have a board of directors telling me how to practice medicine. Instead, I can really individualize my care to whatever's best for a patient. And so at Conceptions, I think that we have, the best of all worlds, in that we can really individualize treatment when it's needed. That is a great segue for the next patient's question, which is, what are the different types of IVF? Is one more successful than the other? So in general, when today was just describing something called conventional IVF, meaning most patients these days are doing what's called a conventional IVF cycle, where you're on birth control pills during that first prep month. When you stop the pills, you get a period, and it's with that period that you'd start both recombinant FSH or Follistim and Menopur or HMG. And most of our patients are doing what are called antagonist cycles, which allows us the ability to minimize your risk of developing complications like ovarian hyperstimulation syndrome. And so most patients are on what are called antagonist cycles. That being said, we have lots of other protocols there. So there are things like a microflare protocol. There are protocols called duostim, mini-stim. There are different ways of priming, using estrogen, using testosterone. It really is varied. As one of my research mentors once told me, that there is an art to ART, or assisted reproductive technology. That's where you really need to rely on your clinical team to see what recipe is going to be best for your for your family size goals. Let's see, the other question, this question I won't answer because it's a personal medical advice question. I get them so often, but you should talk to you should meet with your fertility doctor if you have specific questions about your care. And then how long does it usually take from meeting doctor to retrieval to first transfer? So in general, I tell patients 1 month from initial consult to regroup, and then 6 weeks to get to egg retrieval, or 2 months. So now we're at 3 months. And then in general, about another 2 months before embryo transfer. So really from the first time you meet me, it is not uncommon that it would take between 4 to 6 months at the earliest that you can move forward with embryo transfer. One thing that I tell patients all the time is take it one step at a time, because I even hesitate to give that much information, because sometimes patients just start planning their life, they plan their due date, and we just met. There are so many things that can happen along the way of the timeline. And so I think it's really helpful for us to just focus on one step at a time. So I usually say, okay, well, we just met, so let's plan to meet again next month, and then we'll talk about the next step. And that way it's more likely to give you an accurate reflection of what your timeline is going to be in real life. And then this question, so this question was regarding HPV. So how does HPV affect IVF? So HPV is a virus that the majority of people have been exposed to. HPV is associated with genital warts, but it also can be associated with cervical dysplasia or cervical cancer. So that's why we want to make sure that all our patients are up to date on their healthcare maintenance and that they've had recent pap smears to screen for cervical cancer. Patients that have abnormal pap smears will often undergo treatments to remove unhealthy cells. So one that many people have heard of is something called a LEEP procedure. And so, typically LEEP procedures are safe and don't impact your fertility, but patients that have had multiple LEEP procedures may benefit from meeting with a specialist to talk about how it impacts their future pregnancies. So that was all the questions I had. I will keep my phone out here, not because I'm texting anyone, but because I'm just going to see if anyone else pops up any questions.
And then you can go ahead and, anybody with questions, you can go ahead and type them into the chat, and then I will read them aloud. Dr. Grindler, I know one question that we get frequently is, what are types of things that we can do to kind of optimize health, optimize, how we're feeling going into IVF treatment?
Yeah, great questions. So this is literally what I dedicate a lot of my free time to, is looking into what patients can do to stack the odds in their favor. So there are things that you can do both from a diet and lifestyle standpoint. So from a diet standpoint, you want to be eating simple, unprocessed foods. So now is the time to really eat as healthy as you can. So if now's the time to eat more whole fruits and vegetables, avoid processed foods, and minimize how much meat you're eating. Similarly, if you're eating grains, you want to avoid highly processed grains and choose things like wild rice or whole wheat, as opposed to refined carbohydrates. Another thing that I tell patients to consider is adding tofu to their diet. So women who add tofu to their diet can have better embryo development. So 1 to 2 servings of tofu a week is a cheap, easy thing you can do. And then I also strongly recommend that patients that are undergoing IVF, that women will avoid using or drinking any sweetened beverages during IVF, because it's actually associated with worse outcomes in the lab. Another thing that I'm personally really interested in is environmental toxins. So exposures to chemicals that we're all exposed to in our daily life, things like bisphenol A or BPA or phthalates. And so that is like a whole nother lecture that I could give another time, but I have a lot of content available on my Instagram if anyone's interested in learning more about environmental toxins.
Perfect. A question that we had come in: how much should a patient expect to interact with a physician versus a nurse?
Great question. So a lot of times it depends on your physician. So I give all my patients at the initial visit, they have access to my email, and I want to be as available as you need me to be. That being said, I'm looking at all your results as they come back, but I'm not going to be the one that calls you with each result. So, if your lab results come back, your nurse is going to be the one who calls you with the lab result, even though I'm the one who looked at the result and said, keep going in the same dose of protocol. You're not going to necessarily hear that directly from me. You'll hear that from the nurse. And so I'm as available as patients need me to be. I have some patients that email me more often than others, but it's really just up to you to decide. I'm always happy to schedule a regroup. Most of the time, patients can expect to meet with me twice before IVF and then after IVF before embryo transfer. And that's standard. But I certainly have patients that meet with me more or patients that meet with me less. So I'm happy to personalize it to whatever works best for you.
Perfect. Another question. Do you have advice on how to select a fertility clinic? There seem to be so many options. It's overwhelming.
Oh my goodness, I agree. So I think it's really important that first and foremost, that you feel comfortable at the clinic. And so, I'm trying to decide how to phrase it differently, but, where you get treatment is really important, especially if you think that IVF may be indicated or you're considering doing technology like egg freezing. So first and foremost, you want to be sure you feel comfortable with the vibe of the clinic. As non-specific as that is, you want to feel welcome and accepted and that you're given all the care that you need access to. The second thing that you need to, that I recommend that you check is the success rate of the clinic. So even if you're hoping not to need IVF, it's in your best interest to find a clinic that does a lot of it. Because if they do a lot of IVF, then if you do need IVF or any form of advanced fertility treatment down the road, you're not going to have to waste time and change between clinics because you're already in the right place. And so a lot of times patients will ask me, well, how do I know what is a good clinic? So the CDC, or the Centers for Disease Control, mandates that we all report our live birth rates. And so you can look up in IVF clinics or fertility clinics success rate or their live birth rate if they are doing IVF, and use that to help you determine a surrogate marker for how good the IVF lab is.
Okay. Do you provide any mental, emotional support along the journey? What outside supports do you suggest adding to one's fertility team?
I love that question. So at the initial consult, I tell all my patients, look, what you are going through is real. Even before you start any fertility treatment, the majority of my patients are dealing with underlying grief, anxiety, and depression. And so I just met you on that first consult, but I tell all my patients, if you don't feel like you're your best version of yourself, you are worth investing in now. And so I really leave it up to the patients themselves to decide what makes the most sense for them to be the best version of themselves, whether that's stress reduction through yoga, meditation, or acupuncture. Other patients want therapy. Other patients require medications. It's really up to you to decide ultimately how you show up as your best version of yourself. And so I am flexible in the method with which you deal with stress reduction, but I encourage all my patients to consider treating for stress reduction, proactively.
And I'm just going to add to that, on our website, we do have a list of licensed counselors that really are specialized in fertility treatment, pregnancy loss. So they have a really, specific, they're very specialized. So that is a great resource if you're looking for somebody to go on our website. And we do have, they aren't with conceptions necessarily, but people that we do refer to.
Yeah, and they're great resources. Even if, I think it's just so nice to not have to explain to a therapist what a failed IVF cycle means. And so those counselors that are on our list are really people that's really all they do is they talk to couples who have failed treatment cycles or are considering changing treatment decisions or treatment courses. And so they're really the best people to advocate for you and your family.
Any other questions? These have been really, these have been great questions, but we do have a little bit more time if anybody wants to ask something. What, in your opinion, is the hardest part of this ride?
Ooh. So I think the hardest part is the grief that comes at different phases. So I didn't answer the question directly. So when you have infertility, for many patients, that is the first time they're experiencing grief, where they have a real loss. They were hoping it would happen naturally, and instead they're grieving. Or they have to meet with me. And so I think that being proactive and knowing that grief hits us all at different points of our journey. Some patients are fine at the initial consult. Others are very, emotional and tearful at that initial consult, the fact that they even need help. Other times patients do fine during fertility treatments like IUI, but then the decision to go to IVF is what really challenges them. And then for other patients, they can feel worse in IVF with the nitty-gritty day-to-day updates because so much is on the line. So grief can hit us all in different ways and at different stages. And so I just think that it's important that you have an open dialogue with at least one person in your life about what you're going through for fertility treatments, so that you have someone that you can talk to about when things do get hard, and know that stress is normal, but you can choose to determine how much you're going to let it impact your life.
Another question about thoughts on going through IVF during COVID.
Yeah, so a lot to unpackage there. So just so you know, COVID is unlike the Zika virus. We have no concerns about the impact of COVID on your fertility. I have no concerns about the impact of COVID on early pregnancy, pregnancy loss, or really anything regarding your fertility or early pregnancy development. And so Zika was something that was associated with birth defects, and so that was a big deal. The major problem with COVID and doing IVF during a global pandemic is the risk that if you were to get sick during an IVF cycle, that we would have to cancel your cycle. And so you would eat the cost of whatever medications you had kind of had up to that point and wouldn't be able to proceed, because we just don't have the capacity, and it's not in your best interest to do IVF if you have an active COVID infection, for the safety of yourself, but also our patients and other staff.
Any other questions? We have a question about offering support groups. So we have started recently. If you follow us on social media, we will have from time to time some meetups, and we will kind of choose different groups for those. They're not necessarily support groups. It's kind of more of a social gathering, and we choose, women over 40 or single by choice parents, or so that's not necessarily support for IVF necessarily, or we haven't zoned in on those yet. But like I said, we do, kind of direct you to other resources on our website, and then specifically the counselors.
And I'll just say that, their social media has really become such a mainstay of way of patients connecting with one another. And so I always encourage patients to consider use of social media, but I always caution to use it with a grain of salt. So, what people write on social media and what they share on social media may not actually be true or the case. And so if you have questions, or if you're really feeling you have concerns about your treatment, it's time to get off social media and contact your doctor.
And just to add on, there are also some local support groups, and Resolve is a really great resource to kind of help direct you and connect you to those. Another question that I got is, what do you feel Conceptions is best at?
I think that we are really good at individualizing patient care. And if you need IVF, this is the place to be because we've got the best IVF lab in the country.
Anybody else? Thank you, everybody, for joining. I hope that you found this helpful. We have our number listed there, and if you want to call and make an appointment, also I can put my email in here in the chat if you have any follow-up questions that you would like me to relay. I certainly can. Or any questions about scheduling, anything like that, you can contact me there. Otherwise, I really hope this was helpful, and thank you again.
Bye, thank you.